All right, good afternoon, everybody. Thank you so much for coming. We're going to get started. So my name is Dr. Jeremy Beitler. I'm a pulmonary intensivist at New York University in the US. We're pleased to be joined today by two truly distinguished speakers who are going to make compelling cases for and against the use of oxygenation to titrate PEEP. And we can both smirk as Danny makes the case here for the pro. Up first is Dr. Daniel Talmor, who's chair of anesthesia at Beth Israel Deaconess in Harvard Medical School in Boston, Massachusetts, who's going to make the case advocating for PEEP titration based on oxygenation.
Okay, thank you, Jeremy. Thank you to Jean-Louis for giving me a topic that's the exact opposite of what I think. So I'm pro PEEP titration based on oxygenation as opposed to PEEP titration based on physiological parameters. And we'll start by reviewing the mechanisms of ventilator-induced lung injury. So we have stress, which is high pressure on the lung, strain, which is high volume, and both of those combine with cyclic collapse, so atelectasis in the lung. In the right lung, so in a lung that's in danger, can lead to lung injury. So PEEP generally is considered to reduce or prevent that cyclic collapse or atelectasis. Now, in the last few years, we've added repetition to the repertoire and come to understand that if you deliver 20 dangerous breaths a minute, that's more dangerous than 10 dangerous breaths a minute. Now, this is the seminal trial in ARDS showing that if we give low tidal volumes, 6 mLs per kilo, as opposed to very, very high tidal volumes, 12 mLs per kilo, we can reduce ventilator-induced lung injury. And that's the difference between these two survival curves. Now, the question is, can we do more? So is this mortality that remains in these ARDS patients, is that something that we can prevent by further titrating our ventilation, or is that mortality that's inherent to the underlying condition of the patient? So the question is, can manipulating PEEP make a difference for that remaining mortality in ARDS patients? And the premise is that if we increase PEEP or give an appropriate number of PEEP, we can prevent that cyclic opening and closing that leads to ventilator-induced lung injury. So there's been numerous clinical trials of higher versus lower PEEP or physiologic versus non-physiologically based PEEP. This is the summary of the recent ones, and I'll talk a little about each one of them. So there's been those where it's been a straight up high versus low PEEP table. And the two that did that methodology were both negative. So we have on the left-hand side the alveoli trial from the ARDSNet. On the right-hand side, we have the LOVES trial from the Canadian Critical Care Group. Both of those showed absolutely no difference between a higher PEEP FiO2 table and a lower PEEP FiO2 table. And the reasons those failed are clear. So if you have a group of patients and you take them and you ventilate both with 6 mLs per kilo and you push one group to a higher PEEP, actually there are two separate populations in that group. There are the recruitable patients, or the non-recruitable patients, in whom increasing PEEP will increase the driving pressure, will increase the injury to the lung, and perhaps the injury to the cardiovascular system. So there, the injury from a high PEEP outweighs the benefit. There's another group, the recruitable patients, and in that group, you increase the PEEP, you recruit lung, the driving pressure goes down, and those patients, the benefit outweighs the harm of high PEEP. So if we don't select out certain patients, then we are going to combine those who are harmed and those who are benefited from higher PEEP, and the net result will be a negative trial. And that's probably what happened in LOVES and alveoli. They included all patients, treated them the same, and got a negative trial. So there's been attempts to use physiology to set PEEP going back to 1975. So this is a paper by Dr. Peter Suter, who described setting PEEP on the best compliance. And that PEEP level was that which obtained both best compliance, best oxygenation, best hemodynamic response, highest cardiac output, all of those things. And Dr. Suter described that way back in 1975. So best compliance to titrate PEEP. This handsome gentleman here described in 1996 in the New England Journal an approach using the PV curve to set the PEEP. So you can see on the right-hand side the PV curve. You can identify a lower inflection point, set the PEEP to the lower inflection point. The lower inflection point has been called lately other things, airway closing pressure, things like that. Essentially, it's all the same thing. It's the point at which your ventilator breath begins to distend the lung. So this study is difficult to interpret because it used high tidal volumes, and we don't use those anymore. So that kind of muddies the picture. But it's more difficult to put in practice because the lower inflection point is sometimes difficult to find. And looking at a PV curve, if you don't do it properly, which is a to-do, you won't find a lower inflection point. And even if you do it properly, you might not find the lower inflection point. So now there's automated methods. It's a little easier, but it's not widely available to all intensivists. There are two other respiratory mechanics-based PEEP trials. So you can see the EXPRESS trial on the left. That's out of France. There they set the PEEP to the level that would achieve a plateau pressure of 28. So they set the ventilator, low tidal volumes, and then increased PEEP until the plateau pressure got to 28. Interesting concept, intuitively strange, because what that means is the most compliant lungs will get the highest level of PEEP, which you would think you would want to do the exact opposite. But they showed no benefit. And the ART trial, which actually showed harm, so increased mortality on that black line to higher levels of PEEP set by best compliance. Now, the ART trial had multiple issues explaining why it failed. And finally, our own, so Dr. Beitler and myself, EPVent-2 trial setting the PEEP level based on the esophageal pressure measurement to achieve a transpulmonary pressure of 0 at end expiration. So what's the common theme? You have multiple physiology trials have failed to show a difference, okay? You have, and maybe one of the explanations is this, and this is from a paper that came out last week, but the message has been out there before. You can see PEEP set by best compliance, PEEP set by EIT, and PEEP set by transpulmonary pressure. And if you look on the right-hand graph, each of them gave a completely different answer. So these are world's experts, including Dr. Amato, who will try to explain this away in a minute. But you have a PEEP of 8 with the transpulmonary pressure, a PEEP of 10 or 11 with EIT, and a PEEP of 14 with compliance-based, best compliance. Now, these are pigs. It's in a lab. It's different than humans. But what is it, 8, 10, 12, 14? Don't know. And this goes to one of the issues with physiologic-based PEEP, that it's highly technically, it's highly dependent on technique. And if you're not doing the technique correctly, you'll get to the wrong answer. So choose your favorite physiology, but at least do it right before you set the PEEP. And some of these are especially finicky to manage at the bedside. So on the other hand, these were a group of world experts wrote this paper, so I assume they did know how to do it technically correct. They just got to different answers. So what do intensivists actually do? So below I've put the ARDSNet lower PEEP table and the ARDSNet higher PEEP table. And on top of that, I've put the PEEP levels set in the lung safe survey that was done about 10 years ago. So that was an international survey, intensivists responding, describing their mechanical ventilation practice in ARDS. And what you can see as you get to 100% oxygen, so 80 to 100% oxygen, people are giving a PEEP of 10, okay? If you look at the ARDSNet low PEEP table, at 80% oxygen, you have to give a PEEP of 14, getting up to 24 at FiO2 of 1. And the high PEEP table, you're at a PEEP of over 20 right away, okay? So intensivists aren't actually doing physiology-based PEEP. They're not even doing ARDSNet-based PEEP. They're all defaulting to a lower PEEP level. Now, you could say this means that intensivists don't know what they're doing. On the other hand, you could say that intensivists are learning at the bedside that it could be dangerous to give very high levels of PEEP based on physiology. So getting back to the EPVent2 table, you can see in the EPVent2 table, we used the high PEEP table from the ARDSNet network, a little modified, but getting right up to a PEEP level of 20. And you can see there the PEEPs that were delivered in the EPVent2 trial compared to the lung-safe PEEPs, so substantially higher. Now, what does that mean for the trial? One, it means that the trial was negative, but two, it means even if it was positive, it's difficult to know what to do with it because we're comparing to a control group that nobody actually uses. And that's one of the lessons we learned in our new physiology-based trial. So very difficult to interpret physiologically based trials when we're using control groups that are unrealistic and don't represent the pattern in the community. Another reason trials might fail, and these are slides I need to thank Dr. Beitler for. So in any disease, you have a mortality there, the overall mortality, and you have the attributable risk to ARDS. And I was getting to this when I showed that slide of low tidal volume ventilation from ARMA. If the attributable risk from ARDS is constant, then our ability to show a mortality effect is going to depend on the attributable risk of the underlying disease. So if you're dying from severe sepsis, it may be that what you do with the ventilator doesn't really matter. You can't show a difference because the overwhelming 90% mortality is from the sepsis. On the other hand, if you have a group of patients with a relatively benign disease, let's say a head injury you die of head injury, but that's not a good example. But trauma, who generally do well in the ICU, et cetera. If the attributable mortality to the non-ARDS portion of your disease is low, then you're much more likely to show a difference in the trial. If the attributable mortality, I said, of your sepsis or whatever is high, your ability to show a difference in the trial is low. So by mixing multiple types of patients, we may have caused all these physiology trials to fail. And this is the ART trial, so we said it had an increased mortality. The increased mortality was actually in the sicker patients. Okay, they were dying of their underlying disease. The patients who were less sick, there was no difference between the higher or lower PEEP. And PEEP isn't enough. So here we see this is the hypothesis behind our new PEEP trial or our ventilation trial, that you need to combine it with limitation of the distending pressure, which in our trial would be limitation of the driving pressure. So the problem with the physiology trials is not necessarily that it's wrong to use physiology, it's just that they haven't been properly executed versus a proper control group. So to sum up, pro-PEEP set by oxygenation, it's simple. It's based on expert opinion. Those tables weren't just made up. Experts sat around and thought about them. Empirically, it's close to what clinicians do. We all use lower levels of PEEP than most physiology trials will show. And physiology trials of PEEP, even though I do physiology trials of PEEP, haven't shown a benefit. Each physiologic method gives a different result. Ask Dr. Amato about that when it's his turn. Raising and lowering PEEP in isolation is not enough. So the trials where you set everything the same and just raised or lowered PEEP, that's just not good enough to show a difference. And the patients who are very sick may be too sick to show benefit from a high PEEP in a trial. So overall, in the lack of any other evidence, I would say that we should use PEEP titration based on oxygenation until the physiologists among us can design a better trial and show us differently. Thank you very much.
That was fantastic. Thank you so much, Dr. Talmor. Now my pleasure to introduce Dr. Marcelo Amato from Sao Paulo, Brazil, who's going to convince us that we should not pay attention to oxygenation as we titrate PEEP.
Thanks, Danny. You really did a better job than I was prepared to. I will start with this idea that, okay, oxygenation is the simplest way. It's close to what physicians do, but is there any rationale besides the fact that we are afraid about bad numbers at the bedside? I don't know. The more I think about oxygenation, the more I think it's completely wrong. And starting here with the famous ARMA trial. So we have here the high tidal volume arm, the low tidal volume arm. And then when we look at the oxygenation of these two arms along the week, it's in the low tidal volume arm, oxygenation was much worse. So we are protecting the lung, but oxygenation was much worse than in the control group. So the minimum here is that lung protection has nothing to do with oxygenation. And then, you could say, this is because this is tidal volume, and tidal volume, if you're using high tidal volume, you're having tidal recruitment, and this improves oxygenation in a dangerous way. Yes, but let's see what happens about PEEP. Let's suppose that a trial improves oxygenation based on PEEP. Does this mean that these patients are doing better? It's interesting. I think oxygenation is very confused, because it has a very complex physiology. And this is one of the reasons why following oxygenation, we may get into a trap. Let's see this new study performed in COVID patients, the recruit. So they splitted the population in 3 subgroups in terms of recruitability: high, medium, and low. The high means that recruitability was above 40%, so more than 40% of the lung was completely collapsed. And then this is the collapse and hyperdistension curve of the 3 groups. And as you can see, the crossing point here suggesting the ideal PEEP for low recruitability was 10, for the high recruitability was 16. And then, obviously, these low recruiters, they have much more hyperdistension than the high recruitability group. But when you look at the PF ratio of these 3 subgroups, low, medium, and high, they are absolutely equal. So even... and it's interesting because this is baseline. And then you could say, but let's see the response to PEEP. And there is this analysis in the paper. And then the response to PEEP is the same in terms of oxygenation for the 3 groups, at least up to the PEEP of 16, which most people use at the bedside. So in this other paper from the group of Ewan Gallagher, I participated in this analysis. They took a look in the PEEP studies just showed by Danny. And they tested the hypothesis that the improvements in oxygenation could be related to a better outcome. Let's suppose that I increase my PEEP. When I see a good response in terms of oxygenation, is this really meaningful? And then we tested the following. We tested if the response in driving pressure or the response in oxygenation following a PEEP raise, is this correlated with your outcome? And then, as you can see, if you increase your PEEP and your driving pressure drops, or vice versa, if your driving pressure increases, your mortality increases. And this happened in the alveolar trial and the express trial. Both, they are low tidal volume, high PEEP studies. But the response in oxygenation, so for instance, if you increase your PEEP and let's suppose that you improve your oxygenation, we typically at the bedside, we are very happy about this. There is no correlation with the outcome. So changes in so baseline oxygenation does not relate to outcome, and changes in oxygenation are not related to outcome. So basically what we see in this paper is that only mechanics is correlated with the response of and the outcome. So this is why I like a physiology-based approach to PEEP. I think Danny made a good point that the different methods don't agree very much with each other. And this requires a lot of, let's say, care and detail in the analysis when comparing the methods. But let me try to convince you that this is the only way to go and the only way that makes sense. And up to now, we have been very successful in animals. And I believe that when we are successful in animals, we have just to jump the complexity to go to patients, but there is a clear pathway. So because my point is that in animals, a physiological-based approach to PEEP makes much more sense. So because of gravity, even small animals, they have atelectasis if you don't use PEEP. And typically, the animals start to collapse when transpulmonary pressures are below +2. This happens to all the mammals, dogs, rabbits, pigs, and humans. And so in this case, for instance, this animal was very collapsed because the tube was open to atmosphere and the pleural pressures were not enough to keep a positive transpulmonary pressures. And then you have this huge collapse in rabbits. And this happens also in neonates. So you don't have to be a big animal to have massive dorsal collapse. So patients in the ICU are typically like this. When I see this image, I know that this patient is submitted to low transpulmonary pressures. The PEEP level of this patient was 14, but it was not enough to keep positive transpulmonary pressures. When I see an EIT image like this, I'm 100% sure that this patient has low PEEP. It's not enough to overcome dorsal collapse. How much, where this number of +2 comes from? Many physiological studies, starting from Weibel and others, looking at alveolar spaces and how much pressure you need to keep open distal airway space in mammals, supposing that you have a reasonably good surfactant system. And for instance, in this old paper, they were putting the lung inside some air compartments or liquid compartments and testing how much pressure I needed to keep this lung open. It was very consistent. At a transpulmonary pressure of +2, these lungs started to collapse. Okay, so this is an isolated lung preparation. And I have done this many times in my lab. Every time I finish an experiment, I like to see if this is true, even if the lung has a severe lung damage. And to my surprise, it's absolutely true. And let me give you some examples. If I do a PEEP compliance curve in this isolated lung preparation, I see something like this. This is compliance of the lung. It's only lung because it's completely isolated. This is the PEEP level, and this is the compliance, and you see a peak at 2 centimeters of water. But in this case, because atmosphere means zero pressure, is the reference pressure, PEEP levels can be considered as transpulmonary pressures, right? So which means in an isolated lung preparation, you need 2 centimeters of water to have the best lung compliance. But you could ask, oh, this drop in compliance really means that you are collapsing, and this really means that you are having overdistension? The answer is absolutely yes. We could prove because we put these isolated lungs into the CT machine, and we measure how much collapse we had at each transpulmonary pressures. And we did this experiment with sick lungs, with healthy lungs, and in all cases, as shown here, so this is an isolated lung preparation in the CT gantry. So you don't see any parenchymal collapse until you start to have a transpulmonary pressure of +2 or below +2. And then you start to have real collapse. And it's, if you do a very detailed CT, you start to have distal airway collapse and then alveolar collapse, a mixture of both. And you don't have any collapse above this level. So, which means that these compliance curves, which they have a sudden drop at a transpulmonary pressure of +2 or +3, they really mean lung collapse. So this is what we should aim at the bedside. The problem is that measuring transpulmonary pressures at the bedside is very tricky, and we can only use esophageal pressures. And esophageal pressures, they are limited for 2 reasons. You're not measuring the true pleural pressure, you are measuring esophageal pressures, which have some artifacts, and it's very localized pressure because it's very much the pressures in the region of the esophagus. So there is another method suggested by Danny, which is the EIT PEEP titration. So using EIT, we have this kind of graphs where you have the collapsed curve, the hyperdistension curve, and there is a good reason, as I'm going to show, to choose the crossing point, which means that this is the key pressure in which you have a minimum amount of both together, collapse and hyperdistension. In fact, what I'm trying to prove you is that this pressure is precisely the point of maximum compliance if I had an isolated lung preparation, like here, okay? So this crossing point corresponds to this peak of compliance here if the lung was isolated from the thorax, okay? So let's just try to understand this. So first, it's important to know that that EIT matches with CT. So this is CT in black, EIT in red. So they match very much. Good correlation between both methods. And then when we do a PEEP titration using EIT, it's like you have your lung inside, or let's say immersed in the thorax of the patient. And the analogy is like inside a bath of water, or a vessel with water. The chest can be considered as water. And then when you do the titration with EIT, you are doing very much like the curve I showed you in isolated pig preparations. And then for each pixel in the image, you are calculating the compliance along the PEEP steps. And then when you start to see that the pixel has a decreased compliance, you know that they are collapsing, and we proved this with CT. And when I have a relief of or improvement of compliance with decremental PEEP steps, I know that this pixel was hyperdistended. And then it's interesting that each pixel has a different position in the thorax. And then, for instance, the pixels in yellow, they reach a maximum compliance at a different PEEP level than the green ones. But if I put both pixels in the same plot and instead of PEEP, I put transpulmonary pressures in the x-axis, now all the pixels are in the same plot. And then the only difference here is that the yellow is here because it's above the ideal transpulmonary pressure, and the green one is here. But they are following the same curve. And which means that whenever I see this, so the pixels are following the same path as in the isolated lung preparation. So just to finalize, so this is the position of the esophagus. When you have the esophagus in this position, the lower third of the esophagus, and you set a transpulmonary pressure of +2, what happens is that all the pixels above this level, they are going to be hyperdistended because transpulmonary pressure is going to be +6, for instance. And all the pixels below this level are going to have a transpulmonary pressure below +2. And they are going to be here, like the green one. And this is, so that now you can take the whole picture. When you have a titration, and this is an extremely obese patient, even if my PEEP level is 21, very high one, I still matching the crossing point, which means that the transpulmonary pressure of this patient is +2, and I'm obeying the real physiology. The key point here is that, can I get this clinically at the bedside? So having this concept of ideal PEEP for all the mammals. Yeah, you need a very careful titration at the bedside. And what we know for now, and my time is running, and I'm going to jump just to my final slide. Okay, two slides, and then I finish. The first one is to show that in experimental studies, if I choose the crossing point, I have the best and the lowest level of inflammation, and I have the best situation for the cardiovascular system. If I try to apply a PEEP lower than this threshold, I start to have right ventricular failure. So this is the results showing least inflammation, and I have the lowest pulmonary vascular resistance. Okay, and then my final slide. Is this level of PEEP equivalent to PEEP FiO2 tables? Not at all. This is the difference. In the left, you have ARDSNet PEEP precisely following the ARDSNet table. On the right, the PEEP following the best physiology. And they don't match at all. And the difference sometimes can be 10 centimeters of water, which is absolutely unbearable at the bedside. So the question is, do we have the technology to go to this level of refinement for choosing PEEP? I believe so. And I have been working not only with EIT, but also with esophageal balloon, trying to improve this technology at the bedside. I think esophageal balloons are very tricky. And even if you don't put the right amount of volume inside the balloon, you can mess up with the PEEP by 10 centimeters of water also. So the problem is how to improve our precision. And I believe that this is possible, and I'm sure that Danny also believes. Thank you very much.
Thank you so much, Marcelo. I'm afraid we're over time, so we're going to have to leave it there. I'm so sorry. But if you have a minute, if anybody has questions, we can gather at the corner or outside. Is that okay? Yeah, I'm sorry, because we're way over time. All right, thank you all so much.